Well, thank you for inviting me, and thank you for the kind introduction. I think I may have been a little ambitious with my the number of slides, so I may go through a few of them. But I appreciate the opportunity to discuss with you today. Here are my disclosures, and most importantly, of course, all of the discussion of PD-1 and PD-L1 inhibitors outside of nivolumab or Opdivo in squamous cell carcinoma is currently off-label. So this is a schema from the New England Journal of Medicine from a paper by my colleague Tony Rebus, describing the priming phase initially where CTLA-4 is particularly important, and then in the effector phase, there at the level of the tissue, we are of the sense that that is where the PD-L1 interaction is most important. Now, as we've started to see efficacy of the checkpoint inhibitors, I would say that this is the sort of data that makes us most exciting. Clearly, in melanoma, where checkpoint inhibition, clearly with a different class of drugs, the CTLA-4 inhibitors, have been in use for a long time, we now are to the point where people are able to comment on 10-year survivors with metastatic melanoma. We do not know that that is where we are heading with checkpoint inhibitors in lung cancer, but certainly it is intriguing that this concept in a malignancy can lead to these prolonged response rates and survival rates. So first, I'd like to address PD-1 and PD-L1 inhibitors in unselected populations. So this was initially presented with the nivolumab data. Julie Bramer at ASCO 2013 showed a response rate for nivolumab of 17.1%. It was a little bit higher in the group of patients treated at 3 or 10 milligrams per kilogram, and 3 milligrams per kilogram is the dose that people have gone forward with. This is from data that I was involved with, where we looked at 495 patients with pembrolizumab, and what you can see is that the response rate in patients with prior therapy was very similar, 18%, a little bit higher when you include patients without any history of prior therapy. And histology didn't seem to be a big predictor. The one clinical thing that was the biggest predictor was smoking status, and clearly patients who had been former or current smokers were about twice as likely to have a response as compared to patients who were never smokers. And when one looks at the sort of longitudinal outcomes in this unselected patient population with pembrolizumab, what you can see in the green here is treatment naive. Not surprisingly, particularly in overall survival, the treatment-naive patients did quite well, but you can see that that for the previously treated patients, PFS was fairly short, 3 months for the median PFS. Overall survival in the previously treated patients was around 9 months, but as I'll comment on later, clearly by selection, you were able to change some of those numbers to the point where there were groups of patients who did significantly better. Overall survival with Checkmate 017, this was a study looking at squamous cell carcinoma. Early on in the development, there was some indication that squamous cell carcinoma might be a better target than non-squamous non-small cell lung cancer. And so this study was stopped early, and the overall survival benefit was quite significant, 9.2 months versus 6 months. And as you can see, responses were both more frequent in patients who were randomized to receive nivolumab as compared to docetaxel. And in addition, the duration of those responses was also different, with about 2/3 of the patients who responded to nivolumab continuing to respond at the time of the data cutoff, whereas about 1/3 of the patients who were randomized to docetaxel. So Checkmate 057, this is a study in non-squamous non-small cell lung cancer, and here again you see a survival benefit. The numbers are clearly better here for both groups. It was around 9 versus 6 months for the squamous. Here it's about 12 versus 9.5. And I would also point out that this is pretty impressive to find a group of patients in non-squamous disease in a second-line setting who have over a year survival. So One additional data set that I'll address is the Poplar data set. This looks at atezolizumab, and it is an inhibitor of PD-L1. That, in an unselected population, also at least numerically led to improved overall survival. It was a fairly small study, did not reach a significant p-value, but again, a fairly small study. Now, back to my original slide on the checkpoint inhibitors, what does this mean for patients? I think this article by Scott Gettinger in JCO is sort of the most hopeful. It's sort of following some of this data. We don't have 10-year data, but we do with the original nivolumab experience. We do have data out to 3 years, and we still see a response rate in the teens at 3 years. And it's certainly exciting when you have patients in this setting who are doing well, either on drug or who have stopped drug but have had responses to these drugs, who are really out years from therapy, and many of them are doing quite well. So now to address sort of doing quite well, obviously with any new class of agents, safety is going to be an important consideration. The safety consideration with the PD-1 inhibitors that probably has been the most concerning has been pneumonitis, and there were several deaths in the original nivolumab study from pneumonitis. I'm happy to say that overall that has improved. If you look at the 3 largest data sets recently, the Keynote-001 study, the Checkmate 017, and the Checkmate 057, I think between all of those studies, there's one reported death from pneumonitis in around 1,000 cases. So that has certainly improved with greater recognition. So for pembrolizumab treatment-related adverse events that we're seeing, the most common was fatigue. And if you look at immune-related adverse events, the most common clearly was hypothyroidism. There are a few patients who would have a hyperthyroid flare. Sometimes that could be sort of clinically manifested, but otherwise, if you're paying attention and following the TSH, it's been very easy to correct, and it's generally been well tolerated. I really like this slide. This is from the Poplar presentation at this year's ASCO. This is looking at atezolizumab, and this slide looks at the difference where you have sort of adverse events that are different between the arms. And what you can see is that in general, the toxicity profile for docetaxel, which is in red here, generally is worse than what's seen with atezolizumab. Now, I've been now pointing out to people for a while that sometimes you have to be a little bit cautious in these. Alopecia is not, obviously it's an adverse event, but it's not what generally drives people the most nuts. And a grade 4 pneumonitis and a grade 4 neutropenia are not the same thing. That being said, I think when we talk to our patients in the clinic, they generally have been very pleased with the toxicity profile. Again, this is just to mention that in patients who do develop pneumonitis, that it is important to start steroids early, and presumably a recognition of this is the reason that after several deaths in a small number of patients in the original nivolumab study, that in the last 1,000 patients that have been reported, I think there's only been 1 death. So now to get to the evaluated biomarkers. So there was an initial expansion of the Keynote-001 study looking at pembrolizumab, where we looked at for response. And what we found was that about a quarter of the patients responded to the drug. But the other thing is that that study required that we have tissue on all of these people. And when we looked, of the 6 patients that we had tissue on that had responded to the drug, they were in the 9 patients who had the highest level of PD-L1 expression. So that you basically could say that in that small subgroup of people, everyone who had a response was in sort of the top third of patients for PD-L1 expression. So that led us to look very closely at PD-L1 as a biomarker. This certainly was not something that was done by our group or Merck alone. There's a paper that Roy Herbst has in Nature where they looked at atezolizumab, again, a PD-L1 inhibitor. They've evaluated their data somewhat differently. They've looked at PD-L1 expression not only on tumor cells but also on infiltrating immune cells, and they have found that, at least initially, to be a very good predictor of response, and now they're looking at both PD-L1 expression on the tumor cells and the immune infiltrating cells. Interestingly, and I'm still having my own sort of difficult time getting sort of sorting this out, they have evaluated that both the tumor cell and the immune infiltrate are important, but if you look, they don't necessarily track that well together. So this is data that was presented at ASCO, and if you look, you can see that the group of people who have high level of staining in both TC is the tumor cell, IC is the immune infiltrate, essentially there's nobody who has the 3+ staining in both. And in fact, the overlap isn't that good either in the lower groups of patients. Now, certainly there have been other predictive biomarkers that have been looked at and will be looked at and try to get additional data regarding this. This is work again from my colleagues Tony Ribas along with Paul Toomey, looking at the importance of infiltrating immune cells. And one other thing that I was involved with, but was led by Naya Rizvi, Matt Hellman, and Tim Chan in New York, was looking at the role of mutational load. There has been some thought that mutational load is particularly important, and when you look at tumors that have higher degrees of mutation, what you can see is that it tracks pretty well with tumors where PD-1 or PD-L1 inhibitors have been efficacious. And what we were able to show, again, in a paper by Naya Rizvi in Science, was that patients who had a higher number of non-synonymous mutations, so mutations that would lead to an eventual change in the resultant amino acid, so a change in the protein, that there was a clear difference, even in a small number of patients with this higher number of mutations being more likely to respond to the drug. And we were even, and this is a busy slide, but following basically a specific immune response to one antigen, and showing that when the patient was responding, basically there were particularly high number of T cells directed against that, which then receded as the patient's burden of disease lessened. So now to discuss efficacy in PD-L1 selected populations. So when we looked, and this is data that's now been published, we sort of divided the group for pembrolizumab into patients who did not have any staining, patients who had sort of low-level staining. PS here stands for proportion score, and so the people with high-level staining means that at least half of their tumor cells expressed PD-L1. And when you looked by that grouping, you could see that almost half of the patients had a clinical response when they had this high-level staining, whereas only about 10% of the patients who had low-level staining. And it was pretty consistent between previously treated and treatment-naive patients. Now, one question that people have very fairly asked is this a cutoff? Or is it more of a continuum? And there are limitations of this data. It is small sample sizes for some of the groups, but overall, it at least begs the question that this 50% cutoff may not be a sort of a cutoff and more of a continuum, that the higher level of staining is greater. If you look, the responses were clearly better as you went up in terms of the degree of staining for PD-L1. Now, one other question that I think is particularly interesting is does this indicate a group of people who are more likely to have a good response? So maybe you had responses in the people who didn't have any PD-L1 staining, but they're sort of lousy responses. Their disease gets better, but then it immediately gets worse. That really is not the case. The patients who had low-level staining who responded appear to have done just as well as the patients who had a higher degree of staining. This slide is looking at duration of response. I think I've never shown this slide with Alice in the room, but we, when you look at a waterfall plot based off this looking as if it were a cutoff rather than sort of a continuum, it doesn't perform as well as crizotinib would in selected populations. But still, it clearly does look, it has the shape that we are used to seeing in a targeted therapy, which again is a little bit hard to reconcile with the quartiles, where it doesn't look like you have that absolute cutoff the way you would with an EGFR gene rearrangement or a ROS1, although perhaps there are also people even in those where there are a lower degree of things. So maybe it's not even there, it's not an absolutely absolute, but certainly more absolute than what we would consider this to be. So when you looked by staining, certainly looking at in previously treated and treatment naive patients, the patients with high level staining for PD-L1 did much better. And in fact, one of the things, this is progression-free survival and overall survival that remained true. And for overall survival in the patients with staining for PD-L1 in at least half of their tumor cells, what you see is that we weren't able to, with 10.9 months of follow-up, we weren't even able to give a lower limit for the 95% confidence interval in the treatment-naive patients because they were still alive. And so the other question that becomes important with that is, does that mean, is that because PD-L1 expression or high PD-L1 expression is prognostically favorable? The checkmate studies would indicate that it was not. Now, these studies are a little bit different in that whereas the pembrolizumab study required that patients would have a biopsy around the time of treatment, these studies largely used archival biopsies. Checkmate 057, interestingly, this looking at squamous cell did not show a big difference, and this is a very, very busy slide, admittedly, but basically in all of the subgroups, at any level of PD-L1 expression, it was better to get nivolumab than it was to get docetaxel. However, that wasn't necessarily true in the Checkmate 057 study. This is a study that was looking at non-squamous non-small cell lung cancer. And if you look here, this has one of these sort of crossing of the curves that that we're used to seeing. So when we show, for instance, data from the IPASS study looking at an EGFR inhibitor versus an alternate therapy in patients who have an EGFR mutation, where you actually have the curves crossing because you're looking at two separate populations. And so that's at least what you see here in progression-free survival. And when one looks at overall survival based on PD-L1 expression, particularly if you look at the 10%, which is on the far right for you guys, the 10% cutoff, you see one group of patients who has a hazard ratio of 0.4 for overall survival, which is pretty impressive. I mean, we're not used to seeing hazard ratios of 0.4. But then the patients who have less than 10% PD-L1 expression, you actually have a hazard ratio of 1.0. So they did not appear, at least at this time, to confer any benefit. Many of us feel that if you follow this out longer, you have to stop the study because ethically, of course, you can't continue the study when you have people who are doing better, that it's very possible that if you followed the study out longer, that this group of patients who have low-level staining still would have an outcome that exceeds docetaxel, although we can't know that. And clearly the outcome of that group of people is not nearly as good with nivolumab in this setting than in patients with levels below it. Now again, this is so this is looking at nivolumab versus docetaxel. It really was favorable in all groups with the exception of sort of never smokers and EGFR mutation positive patients where it was either even or at least numerically favored docetaxel. So in terms of response rate, nivolumab was again superior in non-squamous non-small cell lung cancer, 19 versus 12%, and the median duration of response, again, similar to the slide I showed in the whole group for squamous cell, clearly favored the nivolumab. If you look at, on top you here have, and I think it gets cut off, but it's a progression-free survival and then overall survival. They're divided top and bottom. What you can see is that there are clear differences here based on the expression. And the Poplar data, which again is looking at atezolizumab, where they looked at staining in both the tumor cells and the immune-infiltrating cells, you actually were able to, again, sort of recapitulate. This is just looking at progression-free survival. There is another slide here looking at overall survival. And what you can see, although the sort of any staining or the high-level staining don't, at least high-level staining doesn't achieve statistical significance, the any staining does appear to be better in patients who have some degree of expression. But one thing I will caution is going to be important going forward, there is a group here, at least numerically, where it does appear that they did, if anything, better with the docetaxel. And so it's going to be important to define going forward what that group is. So, so I know I did a lot of data in a short period of time, and I don't know if we take questions now.